Good morning, everyone. My name is Hirotake Hasegawa from Saitama Medical Center, Saitama Medical University. Thank you for having me here today. This is a wonderful opportunity for me to present you guys. My title is Beyond the Dura, the forefront of endoscopic transnasal skull-base surgery. So conventional skull-base approaches are actually very excellent, but it's highly invasive because of the large skin incision, extensive craniotomy, and significant brain retraction. Compared to that, endoscopic transnasal surgery is, needless to say, a minimally invasive approach, and it will give you direct access without crossing critical nerves or requiring a significant brain retraction. And then recently, it began to be applied for a wide range of skull-base lesions, including intradural pathologies. However, when you want to cross the dural border, you gotta be careful that there are brain, nerves, arteries, and perforators in the intradural space, so you need a fine dissection like a microscopic surgery. Also, there's a risk of CSF leakage after surgery, so you gotta do reliable reconstruction. And to do that, you have to prepare a wide surgical field up front. So this is a very important concept, endoscopic microsurgery. For much later reconstruction, this is just my opinion, but I would do inlay duragen for the most deepest part, and then inlay fascia, which is sutures in a near watertight or watertight fashion, only fascia, and the rigid material like bone or hydraulic apatite, sphenoid mucosa, which is covered with the sealant like adherus, and then the sinus packing using a soft material like nasopore. And so regarding the watertight dural suture, I actually summarized my technique in a neurosurgical focus in this year, but it's very important to do meticulously. And there are two types of sutures. One is multiple simple stitches, and the other is continuous sutures. Those techniques are kind of challenging for at the beginning. However, when you practice more, you'll get used to doing this type of suture, and then this watertight suture actually can be done within 45 minutes if you used to it. So definitely, this is the way to take. And with this, you can bring down the risk of post-op CF leakage almost 0%, which is amazing. So also 3D dimensional computer graphic based precise surgical simulation. This is my favorite thing because it can help understand anatomy, determine optimal approach, and then it facilitates the surgery. So let me show a couple of cases. This is the lesion in the juxtacellular region. So the first case is the 52 years old female, large craniopharyngioma. So for this type of case, you gotta be aware that there are multiple perforating arteries, like PCOM, anterior choroidal, superior hypophyseal artery in the front side of the tumor, and back here there is the perforating arteries from the basilar artery. So I'm gonna show the surgical video. So you can see the superior hypophyseal artery in the front of the tumor. So this has to be preserved completely and meticulously with using a site dissection. And then after internal decompletion, you can find the PCOM on the left side here. This also has to be preserved completely with sharp dissection. And to create a space on the right side, I dissected a tumor off of the floor of the third ventricle and then resect the tumor chunk on the right side. This is a dissection from the posterior thermal perforating arteries coming from the basilar artery. And this is the left PCOM, and this is the anterior choroidal artery. And then now you can see the optic tract here. And then you can see the perforating arteries from the top of the internal carotid artery, which also has to be sharply dissected off of the tumor. And unfortunately, there is a strong adhesion between the tumor and the P2, which has to be sharply dissected. And this is a branch of the PCOM. I guess this is the premammillary artery, which also has to be completely preserved because it's gonna cause the hemiplegia on the right side. Again, the tumor is progressively removed, and this is a final view. So you can see beautiful view of the many perforating arteries and uh, cranial nerves. So for this particular case, I did a continuous suture using inlay first year and 6 OPD, 5 OPDS. And then surgery went well. The patient developed no post-op deficit. This is also interesting case, 45 years old female with large planum sphenoidal meningioma, also involving a lot of surgery, a lot of arteries like internal carotid artery and anterior cerebral arteries. So again, very important thing is the wide opening. And then the next thing is internal decompression to mobilize the tumor in order to prepare for the fine dissection later. So this is the dissection from the ACAM complex. Unfortunately, the adhesion is super tight here, so a sharp dissection was required. So this is the left A1, which is also completely embedded inside the tumor, sharply dissected. And this is actually there is a PIR feeding from the left A1, which has to be coagulated and cut point by point fashion. And then meticulously, the lower part of the tumor is removed. And this is, you can see the left humeral arteries with, again, the PIR feeding from this tiny little arteries, which has to be point coagulated and cut. And the rest of the adhesion is uh, taken out, and the tumor is being removed with only a small piece of tumor attaching to the important arteries. So this is a near total resection. The patient went well. She didn't develop any deficit, and her visual disturbance improved, almost fully improved. So regarding the midline posterior fossa, I like this classification using two lines, such as Jurello's canal and glossopharyngeal meatus. With these lines, you can divide the posterior fossa into three parts. And then for the middle part, you can use a standard transclavial approach. And anything sitting in the lower clivus, you have to use a transpharyngeal corridor. And then for the upper region, you gotta do transcriber approach with pituitary transposition. So this is one of the most complicated approach among uh, any other transnasal corridors. So this is a case with the meningioma in the middle and lower clavus. So for this particular case, it requires transcriber with transpharyngeal corridor. So for this type of tumor, I usually raise the nasoseptal flap up front as a part of surgical corridor creation, like this. So this is the sphenoid sinus. The first transcriber corridor is the drilling is extensively performed, and then transpharyngeal corridor to expose the foramen magnum here. And then after that, surgical decompression is really important to mobilize the tumor. With adequate internal decompression, you can mobilize the tumor, and you can find the basilar arteries here, and then cut the tumor along with the basilar artery. So you can divide the tumor into two smaller pieces, and after that you can follow the other arteries like anterior spinal arteries, BS, and AI curve. And also you can also divide the tumor using these smaller vessels to divide the tumor into smaller pieces. And then after that, you can use the Duragen and in the fascia and only fascia. And some, again, there's some fat pieces of fat to fill up the space. And then finally, you can use the nasopharyngeal flap, which was harvested up front to completely fill up the mucosal dehiscence. The surgery went well. The patient her symptoms went away after surgery, and she didn't develop any new deficit at all. So this is, like I said, one of the most complicated approaches. So posterior cranial meningioma in a 59 years old female. So this is the sitting in the upper region. So I have to do transcriber approach with pituitary transposition in order to connect the supracell region and the clavicle region. So to do that, I have to remove the posterior cranial process first. And always the internal decompression comes first to mobilize the tumor. And you can find the superior hypophyseal artery here, which has to be sharply dissected off of the tumor. And this is the left PCOM, which is also embedded inside the tumor. And I like this concept to remove the tumor. I mean, to do internal decompression first before any fine dissection, because you need a space to mobilize the tumor. So you have to cut the tumor along with the basilar artery and resect the right side of tumor first, because the right side was smaller than the left side. And then using the created space on the right side, you can mobilize the tumor in the left side to the right side and dissect these tumors off of these important arteries and third nerve, and finally fifth nerve and sixth nerve. So you can achieve near total resection. So this is the final view. You can see nicely the spectacular view of the anterior brain stem. So the skull-base reconstruction is using the Duragen as an inlay material and inlay fascia sutured in a near watertight fashion. And then I use a fat piece as a spacer and then close the front door to approximate this space. And then finally, everything is covered with only fascia and another pharyngeal flap. Again, the surgery went well. This is a near total resection. She didn't develop any new symptoms after surgery. Regarding the CP angle lesion, so this is a very interesting case with a CP angle epidermolysis in a 29-year-old female. This involved fifth nerve, seventh and eighth ear, and lower cranial nerves. The level is just a middle clivus, but there is a little bit of superior extension, so I had to do a transcranial approach with removal of the posterior cranial process. So this is the exposure of the planum all the way from planum to the clivus. And it's very important to remove the bone in the lateral side to expose uh, the inferior petrosal sinus, and the jugular tubercle has to be removed to get the lateral exposure. So this is the dural cut. So you can see the tumor piece here and sixth nerve and the basilar artery. Usually the adhesion between the tumor and then the brainstem and these structures are not very tough, but it's very important to remember to remove these tiny, the thin tumor capsules, because if you leave these tumor capsules, the tumor will recur. And this is the upper view, mammillary body and third nerve. This is a 30-angle endoscope. On the right side, you can see the fifth nerve, and there you can see the seventh and eighth nerve. Now the tumor, all the tumors are nicely removed, and then the 80% of tumor capsules is also removed. So I take an inlay fascia to achieve a watertight suture, and then covered with another pharyngeal flap because it's transclavian case. Total removal with 80% of capsular removal, and she didn't develop any deficit after surgery. The last case is craniovertebral junction. So this is the 83-year-old female, recurrent foramen magnum meningioma after transcranial approach, because the tumor, at first, because the tumor was really large, and then she was taken to the OR for the transcranial approach. However, the surgery uh, at that time, the surgeons could not take out all the tumor because the main part of the tumor was sitting medial to the vertebral artery. So they were able to take out the tumor part lateral to the vertebral artery. And now the tumor started recurring. So I had to take her to the OR and doing the the transpharyngeal transcriber approach, because the tumor is sitting in the level of the craniovertebral junction. So this is a transpharyngeal corridor. Then you can expose the C1 and also the top of the odontoid processes here. And also you can expose the hypoglossal canal. And then cut the dura, expose the tumor, and always internal decompression is very important. Unfortunately, so this is the recurrent case. So adhesion between the tumor and then the brain stems and then other important arteries and 12th nerve are very bad. So I have to use the sharp dissection to obtain to get a space between these important vessels, brain stems, and tumors. Um, so I had to leave a tiny sheet of the tumor at the surface of the brain stem. But given that the patient is 83 years old, I thought it should be okay. So all the perforating arteries and the cranial nerves are completely preserved. Again, for the reconstruction, take some Duragen as a innermost layer, and then in the fascia, which is sutured to the dura in a watertight fashion for this particular case. and used only fascia, fat, and nasopharyngeal flap to cover it up. And the surgery went well. The patient didn't develop any deficit after surgery. No diffusion high spot at all. So let's wrap up my presentation. So there are various transnasal and minimally invasive transcranial corridors, although I didn't show the transcranial corridors, but you can use you can use endoscope for many approaches in these days. So my point is you can explore the possibility of minimally invasive approach using your own imagination. And then you can also assess the feasibility of your imagined approach through surgical simulation with high resolution. After that, you can move to execution. So thank you very much for listening to my presentation, and thank you for having me here again today. Thank you very much.